Good afternoon. This is Sandy Ramos. I'm a perinatalogist at UCSD, and I'm a director of the UCSD Diabetes and Pregnancy Program. And I wanted to thank the California Diabetes and Pregnancy Program for the opportunity to speak today. I'm going to be talking about diabetes in pregnancy, specifically about preconception and interconception care. I have nothing to disclose. This is an outline of my talk. We're going to be talking about the effects of hyperglycemia on the fetus, specifically embryopathy and the timing, the repercussions of hyperglycemia on fetal growth, as well as fetal programming. We are then going to move over to discuss the importance of preconception care, and then what we can do to prevent type 2 diabetes following a diagnosis of GDM. I wanted to just point out the epidemic that we're having in obesity here, not only nationwide, but also in the state of California. This was data that was collected from 2009. And as you can see, when you look at the range of BMIs across the state, it's quite staggering to see that about 40 to 50% of the state is considered obese. When we look forward into 2013, that number went up to 48%. And then in 2017, which is the last available data, about 51.2% of moms in the state are obese. Mirroring that rise in obesity, we have data on GDM diagnosis between 2004 and 2006, and about 6% of mothers in that time period had gestational diabetes. Mirroring the rise in the obesity rate in the state, we saw that in 2015, the rate of gestational diabetes was 9.2%. So again, a near doubling of the rate of gestational diabetes. So this is a problem that we're going to be dealing with as we go forward in caring for mothers. Let's shift now to the effects of hyperglycemia on the fetus and why we should be concerned about the rising rate of gestational diabetes. First of all, when we talk about diabetic embryopathy, we're talking about congenital anomalies that occur very early in gestation. The rate of congenital anomalies in the general population is about 3%, but in pre-gestational diabetics, it's about 6 to 10%. And the defects that we care most about, or the tissues that are most sensitive to defects, are cardiac defects and neural tube defects. And as a matter of fact, when we look at neural tube defects, the rate among women with diabetes is about 1 to 2%. We think the pathophysiology of these birth defects are high oxidative stress that can lead to early cell death, or what we call apoptosis, but it can also lead to decreased cell proliferation. And high oxidative stress occurs in the setting of hyperglycemia. But hyperglycemia may also lead to altered gene expression, which leads to deviation from the normal fetal development. And when we talk about timing, I mentioned that it occurs early, but how early does it occur? Spina bifida, as early as 6 weeks, anencephaly, 6 weeks. And here is a picture of a first trimester embryo showing what we see as almost a little cap on top of the head, which is actually the brain protruding from the skull, and that's a 3D image of anencephaly. The other concern that we have, or target tissues that are sensitive to hyperglycemia, are the cardiac tissues. And the main abnormalities that we see are transposition of the great arteries, which occurs at 7 weeks, and then VSDs, or ventricular septal defects, and atrial septal defects, which can occur as early as 8 weeks as well. And here I'm just showing you an ultrasound image for orientation. This is the apex of the heart. This is the bottom of the heart. This is the interventricular septum, and I don't know if you can appreciate here this defect on grayscale, which you can see really nice on color scale, where you can see bidirectional shunting, and this is an example of a ventricular septal defect in a fetus. But the more concerning abnormality is having what we call complete atrioventricular septal defect, where you can see here that there is a loss of the septum, not only in the ventricles here, but also in the atria, and you can see the color all the way across, and that's a very dangerous abnormality to have. I think most of us who have done diabetes for a long time have heard of caudal regression or Syrenomelia, which is actually quite rare, but we have had a recent case here at UCSD, and here are some ultrasound pictures that demonstrate Syrenomelia. So you can see here the spine of this fetus in the mid-trimester, and you can see that the spine ends here. And then in this 3D rendering, you can see the characteristic little feet that are kind of in a Buddha position or a V position, which is seen with Syrenomelia, and this baby's spine ended up here. And so again, this is an example of caudal regression. And when you look at other organs like the renal system, again, hyperglycemia can affect it as early as 7 weeks. So preconception glucose control helps prevent birth defects, and that's something that I want you to know as a take-home message. This is a table of an A1C chart just to remind us of what an A1C means. And oftentimes we see women coming in with poor glycemic control, and we get used to seeing A1C somewhere between 7 to 10 range. But as you can see with an A1C of 8, for example, the mean blood sugar is 183. And we know that A1C is very closely linked to the risk of birth defects. This is an older study from Dr. Lucas in 1989, but I like to demonstrate it because it shows very clearly the association with worsening A1C and the rate of birth defects. So if you look at an A1C in the range of about 9 to 11%, the risk of birth defects can be as high as 23%, and over 11%, the risk can be as high as 25%. And I just want to caution you that ultrasound does not detect all abnormalities, particularly if there's maternal obesity. Ultrasound is only limited. The American Diabetes Association does recommend an A1C preconception of 6.5% and to maintain the A1C at this level throughout pregnancy. And that is to minimize the risk of birth defects in these mothers. Not only is there a risk of birth defects early on with hyperglycemia, but there's also a risk of spontaneous abortions. Overall, in the general population, it's about 13%. But if you look at women with type 1 and type 2 diabetes, the risk of miscarriage is about 20%. The etiology is thought to be, again, hyperglycemia in the early embryonic period, which leads to abnormal pathways, which lead to prostaglandin abnormalities and an increase in free radicals and early cell death, which leads to the miscarriage. And then, of course, in 1952, Dr. Pedersen was the first to propose that maternal hyperglycemia was associated with the development of macrosomia in the developing fetus. What he hypothesized was that glucose, of course, crosses freely, and hyperglycemia in the mother leads to fetal hyperglycemia, which then in turn leads to fetal hyperinsulinemia and the development of macrosomia. Back then, the thought was that insulin could potentially be crossing the placenta, but he postulated and was correct in that insulin is too large to cross the placenta. And the way he described the fetal overgrowth was that most conspicuous is obesity with these round cherub's cheeks and the buried eyes and the short neck. And he described that again in his initial studies in 1952, but he was quoted saying this in 1961. And so in order to control fetal overgrowth, we want to have meticulous blood sugar control throughout pregnancy. There are other risks, though, to having diabetes in pregnancy, and those include, because of the development of hyperglycemia in the neonate, there can be an increase in hyperinsulinemia, which then leads to hypoglycemia at birth, which can be quite profound. And neonates are very dependent on glucose for brain function and can develop seizures that can be life-threatening if hypoglycemia is not identified. There can also be hyperbilirubinemia and polycythemia. Again, because of the fetal overgrowth, this can lead to oxidative stress in the developing fetus, and therefore can lead to a compensatory polycythemia, which then develops into jaundice once that neonate is born. There's also respiratory distress due to delayed prostaglandin release. And of course, the more concerning ones that we encounter that we are always concerned about is the risk of stillbirth, as well as birth injury or trauma at the time of delivery. There's some also concerns about the long-term effects of hyperglycemia for the child later on. And Barker was the first to hypothesize that what happened in the womb had an effect on your future health. He took a cohort of men who had coronary artery disease, metabolic syndrome, and compared them to healthy controls. And he looked back at their birth certificate data and noted that the men that had metabolic syndrome, coronary artery disease, were fetal growth restricted at birth compared to normal controls. And so now we have data supporting this theory, which is called the Barker hypothesis, that IUGR in the womb is associated with the development of metabolic syndrome later in life. It appears that there's a similar effect happening in pregnancies complicated by diabetes, such that if infants are born large for gestational age or macrosomic, they have a higher risk of developing adolescent and adult obesity, as well as metabolic syndrome and type 2 diabetes. So we actually think that this is a U-shaped phenomenon, such that undernutrition in the womb, as well as overfeeding in the womb, can increase the risk of adult obesity and metabolic syndrome. And this is a plug for breastfeeding, which seems to help reduce or modify that risk. And we will be talking about breastfeeding more later on. There's also really good epidemiologic data supporting the fact that children born to mothers with diabetes tend to be larger and have a higher risk of obesity later in life. This was a study done in Pima Indians, where the author or the researcher compared siblings not exposed to diabetes in utero to those exposed to diabetes in utero. And here you can see the sibs aged 6 to 9 all the way up to early adulthood. And what she noted was that the siblings that were exposed to diabetes had a higher BMI, about 2.6 kilograms higher than the sibs not exposed to diabetes. And this was an interesting study because these children grew up in the same environment, eating the same diet with the same exercise and environment overall. And so this was an interesting study that pointed out that diabetes may have an independent effect. This was a prospective study done by Dr. Boney, published in Pediatrics in 2005, that sought to look at the effects of gestational diabetes on the neonates as well as the mothers. And I will show you the data about the mothers later on. But as you can see, in pregnancies where there was gestational diabetes and that infant was born large for gestational age, the prevalence of metabolic syndrome in those children, and these are children aged 6 to 12, was about 50%. However, if you were born appropriately grown and exposed to GDM, your baseline risk of developing metabolic syndrome is the same as being born to a control mother or a mother who didn't have gestational diabetes. So I think modifying fetal growth in utero can help us prevent some of the complications. I wish I can tell you that the story is very clear, but obviously it's the mechanisms by which children and adults develop diabetes is still yet to be completely elucidated. This is another study that was published in 2010 in Diabetes Care, which looked at obesity as well as gestational diabetes as independent risk factors for the development of overweight children as well as abdominal obesity. And as you can see, the highest risk for both these things was in that of children born to mothers who were both obese and had gestational diabetes. So obesity also is an independent risk factor. These are normal controls. Here are the normal weight women, and here are the obese women in black. And as you can see, again, they have a higher rate of neonatal obesity and abdominal obesity if their mothers were obese. So again, it's a very complex pathway, and we do know that obesity may be an independent risk factor as well for these outcomes. And then there are further studies that have been published in Diabetes Care looking at what type of diabetes and what the risk is in the offspring. So this was looking at offspring and the risk of development of diabetes. And as you can see, if your mother was a gestational diabetic, even on diet, the risk was 21%. Type 1 diabetes, it was 11%, and normal controls is about 4%. But if you had risk factors but no GDM, meaning that you might be obese and have maybe one abnormal value on your GTT, your children still had a higher rate of having type 2 diabetes later in life, about 12%. So even though we have this nice model that diabetes begets diabetes by leading to high maternal fuels, which then leads to altered fetal islet function, and then the development of childhood obesity and adolescent, impaired glucose tolerance, and then impaired adult islet function, which then leads to either pre-gestational or gestational diabetes. I think that this is a very simplified diagram because it's a lot more complicated than that, as obesity plays a role as well. Now moving on to preconception counseling and what we need to tell our patients before they conceive. The first thing I do when a patient comes into me for preconception counseling when they have type 1 or type 2 diabetes is I talk to them about their glucose control, but also I establish what comorbidities they may have. For example, many times they have heart disease and hypertension. This is an opportune time to discuss their medications, as ARBs and statins are currently contraindicated in pregnancy. And this is an opportunity to ensure that there's no cardiac contraindications to pregnancy by obtaining an EKG as well as an echocardiogram. I also assess for renal insufficiency, and at that initial visit, I review again if there aren't any medications that are for renal protection, and many of our patients with type 2 and type 1 diabetes will be on these medications, including ACE inhibitors, and I'll review what the risks are with ACE inhibitors later on, but they are contraindicated in pregnancy. In terms of baseline laboratory studies that I obtain a creatinine clearance, as well as a BUN and a 24-hour urine protein collection, as well as liver function tests at that baseline evaluation if they haven't had a recent set of labs to review this. And if there is renal insufficiency, then I would want to refer those patients to nephrology, if not already done so, to better clarify their risk. And then lastly, we do discuss other complications such as obesity and discuss the outcomes with gastric bypass if they've undergone gastric bypass, or may recommend that they actually have weight loss before they attempt to conceive. And then assess for any retinopathy. Here's an old table from Creasy and Resnick from 2010. They do have an updated table, but I like this table better. In there, it tells you what we do in terms of the preconception evaluation of a patient with diabetes. We obtain a detailed medical and family history. We perform a physical exam, and then we also assess diabetes assessment as well as nutrition, both at home and also their occupation, because that can interfere with their nutrition. As noted earlier, I try to get an EKG, a cardiac and renal evaluation, as well as a retinal evaluation. And then for our type 1 diabetes patients, obtaining a TSH, also a 24-hour urine protein or a spot urine PC ratio is also good enough. But if I do see proteinuria on the spot urine protein to creatinine ratio, I do collect a 24-hour urine. And then we obtain a hemoglobin A1C and look at what their home glucose monitoring is and advocate for pregnancy when their A1C is less than 6.5. So if their A1C is above that, I recommend preconception control to improve the A1C to that level. And I tell them that I would not recommend they conceive because of the risk of birth defects that we have mentioned earlier. Now, ACE inhibitors and ARBs are contraindicated in pregnancy. There's no proven risk of birth defects in the first trimester. However, with exposure in the second trimester, there has been calivarial hypoplasia, fetal hypotension, renal failure, and oligohydramnios described, which can all lead to IUGR or growth restriction, pulmonary hypoplasia, stillbirth, and joint contractures. So if you see a patient in the first trimester who is taking an ACE inhibitor and ARB, I would just recommend they stop it. However, if they've been exposed to it in the second trimester, I would recommend a level 2 ultrasound to look for any of these abnormalities. With regards to statins, which many of our patients are on for hyperlipidemia, there is concern for limb and neural tube defects. However, larger studies are being collected to look at this association, and actually statins in the second trimester are being explored as a preventative measure for preeclampsia, but the data is still pending. And given that this is all investigational, I do recommend that patients stop statins in preconceptionally or in the first trimester if they haven't stopped it already. We also talk about the additional pregnancy risks because I think it's important for mothers to be aware of what happens in pregnancy and what we need to watch out for, and to empower them to perform, for example, blood pressure monitoring at home. So I do counsel them that if they have hypertension, there can be worsening of hypertension in upwards of 50% of mothers. Preeclampsia can occur in upwards of 30 to 50% of mothers if they already have underlying renal insufficiency along with their pregestational diabetes. We also talk that preeclampsia occurs more commonly at term but mothers with underlying renal insufficiency and chronic hypertension have a higher risk of what we call preterm preeclampsia, which can lead to a preterm delivery. There's also a higher risk of cesarean delivery due to the development of macrosomia. We talk about the impairment of renal function, which there are, as you know, many renal changes that occur with pregnancy, including increased creatinine clearance, and this can lead to further deterioration of renal function, including an increase in proteinuria. And I have had the unfortunate opportunity to take care of moms who have needed dialysis during pregnancy, and this can be quite complex to care for, and many of those mothers deliver preterm because of that complication. They also are counseled that there's a higher risk of diabetic ketoacidosis at lower maternal hyperglycemia than outside of pregnancy. Because pregnancy is a ketotic state, many mothers may develop diabetic ketoacidosis with blood sugars in the 200 to 300, which is not a classic presentation for diabetic ketoacidosis, and that's something the mothers need to be aware of, as well as the clinicians caring for these mothers. And lastly, if you have type 1 diabetes, there's a higher risk of hypoglycemia, particularly in the first trimester, due to nausea and vomiting of pregnancy, as well as dehydration, due to nausea and vomiting of pregnancy, which can lead to the development of severe hypoglycemia. So I want to make sure that mothers with type 1 diabetes also have a glucagon kit available so that their family members are able to treat them. And I usually tell them that I would want somebody to check in on them first thing in the morning to make sure that they're awake, because that's the highest risk time for the development of hypoglycemia is in the morning. So if you see a woman of reproductive age in your practice, I want us to discuss contraception because all contraceptive methods are able to be used in women with type 2 diabetes. That we talk about the risk of lack of adequate glucose control in pregnancy and preconceptionally, and refer them for preconception counseling, because even if they're thinking about getting pregnant, they should see us ahead of time. I want to remind you that about 50% of pregnancies in the United States are unplanned, so this is important information to provide to your patients. Now moving on to gestational diabetes. The incidence initially was thought to be 3 to 5%, but as we learned earlier, in the state of California, it's actually higher, mainly because we are made up of ethnic groups which are higher risk of having gestational diabetes, namely African Americans, Asians, Latinas, and Native Americans. Also, we know that there are other risk factors, including obesity, and we've seen that on the rise in California, advanced maternal age, smoking, and of course, a family history of type 2 diabetes is also a risk factor for gestational diabetes. We know that mothers with gestational diabetes already have some underlying changes in their insulin sensitivity. This was a study published in AJOG by Dr. Catalano many years ago, which sought to look at a cohort of pre-gravid women and then follow them in early pregnancy and late pregnancy and look at the insulin sensitivity. And as you can see, in early pregnancy, there's actually a rise in insulin sensitivity, but then in late pregnancy, what we call insulin resistance. And this is mostly mediated by changes that occur in pregnancy with the hormones, not only progesterone and estrogen, but also human placental lactogen, as well as the weight gain that a mother experiences. And you can see that this change occurs not only in gestational diabetes moms, but also in normal weight women, but it's more profound in women with gestational diabetes. And you can see already that there's a difference in these women who end up developing gestational diabetes in the pre-gravid state or before they even conceive. So type 2 diabetes and GDM share many characteristics. Women will have glucose intolerance, peripheral insulin resistance that I mentioned earlier. There can also be impaired regulation of hepatic glucose production and declining beta cell function in mothers with GDM. So the HAPO study was the first observational trial done to evaluate maternal hyperglycemia and the effects on the developing fetus. This was a multinational trial in which women received a 75-gram 2-hour glucose tolerance test at 28 weeks. And the providers were blinded to the results except if they met exclusion criteria, which was a fasting greater than 105 or a 2-hour value of greater than 200. And then women received routine prenatal care. A 75 gram was chosen because that is what the rest of the world utilizes for diagnosis of gestational diabetes. The US is different in our 2-step criteria. And also, it would allow for evaluating what a woman's 75 gram would be outside of pregnancy, so looking at continual care through a woman's lifetime. And the primary outcomes of the HAPO trial were actually neonatal, so looking at birth weight at greater than the 90th percentile, neonatal hypoglycemia and hyperinsulinemia, as well as the rate of primary cesarean delivery. The secondary outcomes were things we're familiar with but less rare. For example, neonatal fat mass, shoulder dystocia, preterm delivery, preeclampsia, and an ICU admission for the neonates. And what they found was that there was a continuing relationship between maternal hyperglycemia and the primary outcomes. So I'm just going to walk you through some of these charts. This is birth weight at greater than 90th percentile for the neonate. Here's on the y-axis the percentage. And across the x-axis is glucose categories, because you can imagine there's a lot of different combinations between the fasting 1-hour and 2-hour values. So they classified them by worsening glucose values, and 7 being the worst. And then they broke it down by fasting 1-hour and 2-hour values. And as you can see, there's a continual relationship between maternal hyperglycemia, so worsening glucose, both in all levels, fasting 1 hour and 2 hours, and the development of birth weight greater than the 90th percentile. The same thing was seen with clinical hypoglycemia, primary C-section rate, as well as hyperinsulinemia or a cord C-peptide at greater than 90th percentile. And so there was a linear relationship, and there was no inflection point, which was the hope of the HAPO also, to be able to come up with definitive cutoffs for diagnosing GDM using a 75-gram OGTT. When you look closely, though, at the fasting level, and you look at the neonatal outcomes, birth weight, and percent hyperinsulinemia, you see that there's actually an inflection point at around 92, and that's something that we have focused efforts on, is utilizing glucose value of 92 in the fasting state as diagnostic for GDM. And this is the data for 1 hour plasma glucose and outcomes. Again, a very linear relationship, and same thing with the 2 hour value and the neonatal outcomes of interest. So the question does arise, can treatment of GDM help to reduce the fetal risks? And there's been 2 randomized control trials, which are the gold standard trials, to show that indeed it does. The first was in 2005, and this was published in the New England Journal. This is the HAPO trial, which was based out of the UK as well as Australia. They diagnosed gestational diabetes with a 75-gram OGTT. And what they found is that they randomized about 500 women to routine prenatal care versus intervention, which we normally do, diet intervention as well as insulin as needed. And as you can see, there was a lower birth weight, lower rate of LGA and macrosomia, as well as a lower rate of preeclampsia in the intervention group. And this was statistically significant. And as you can see on this side, very few women required medication to control their hyperglycemia. Also, they did not see a higher rate of the development of SGA. Remember, we want to avoid that U-shaped phenomenon of making a fetus growth restriction in the womb, and there was no higher rate of SGA in the intervention group. However, in the United States, we questioned the results since it was not the way we diagnosed gestational diabetes. So Dr. Landon and the group at the Eunice Kennedy Shriver National Institute of Child Health and Human Development, or what we call the MFM network, published their trial, which used the 2-step criteria. However, they did exclude any woman with fasting hyperglycemia, so a fasting value of greater than 95. So this was termed mild preeclampsia. Similarly to the HAPO trial, they randomized women to treatment of GDM versus controls. And what they noted, again, very similarly, was a lower birth weight. The rate of birth weight greater than 4 kilos was half that of the control. The rate of LGA was half that of the control. And again, something unique to this trial was they did measure fat mass, and they noted lower fat mass in the neonates whose mothers received treatment for GDM. And as I mentioned before, there was not a higher rate of small for gestational age within the treatment group. Now, we've talked a lot about the neonates. What are the long-term maternal consequences of gestational diabetes? Because I think that's an important piece to discuss with mothers. This was an interesting study looking at the maternal outcomes of being exposed to GDM. This is a follow-up to the pediatric data that I showed earlier. This was Dr. Boney's study. And she looked at markers of metabolic syndrome, including cholesterol, as well as systolic and diastolic blood pressure. And as you can see, if you look at the cohort of mothers who had gestational diabetes, and this was a follow-up of about 11 years, you see some differences in lipid levels, as well as the systolic and diastolic blood pressure. And the rate of systolic hypertension was about 30% in mothers with gestational diabetes compared to normal controls. And you can see here at 4 years, 5, 6, 7, 9, and 11 years, you can see that there was always a difference in the systolic blood pressure among moms exposed to gestational diabetes. Looking at the development of type 2 diabetes in this cohort, they found that if you had ever had gestational diabetes, the rate of type 2 diabetes was 13% versus 4% in controls, and metabolic syndrome was 27% in those mothers who had experienced GDM versus 8% in the controls. So again, there are some long-term maternal risks to being exposed to developing gestational diabetes in pregnancy. And this was a nice meta-analysis that was published in 2014. And meta-analysis aims to look at individual trials and collect the data and see what the effects are. This is 0, or excuse me, this is 1. Anything to the right of 1 means that there's a risk. Anything to the left, it means that there's no risk. And anything that crosses 1 is not an invalid statistical difference. However, you can see that the majority of the studies do point to an association with the development of metabolic syndrome in mothers exposed to GDM, and the rate of that was about 4% when you took all of the cumulative rates in all of these studies. So again, being exposed to gestational diabetes is associated with the development of metabolic syndrome later in life. So how long does it take to develop type 2 diabetes? This was looking at different ethnic groups, Latin American, women from Africa, Navajo population, and they looked at women and followed them to see when do they develop type 2 diabetes. And it seems that the highest risk time is within 10 years. And for Latinas in particularly, it seems to be in the first 5 years after diagnosis of gestational diabetes or after delivery of their child. So to summarize, we know that gestational diabetes increases the risk of metabolic syndrome fourfold. It increases the risk of development of type 2 diabetes by 4 to 7-fold, and almost 50% will develop type 2 diabetes within 5 to 8 years after delivery of a pregnancy complicated by gestational diabetes. So these are staggering numbers. So how do we modify these risks? So number one, let's talk about how do we do postpartum follow-up on these women. First of all, I just want to reiterate what the American Diabetes Association has classified as prediabetes, so an A1C of 5.7 to 6.4%, as well as impaired fasting glucose, which is a fasting glucose of 100 to 125, and impaired glucose tolerance, which is a 75-gram OGTT 2-hour value of 140 to 199, excuse me. Those people meeting any of these guidelines or these criteria are at higher risk of developing type 2 diabetes. So these are the people that we want to focus on. And then of course, to diagnose type 2 diabetes, an A1C of 6.5 is what we utilize. It's a nice test to do because the patient doesn't have to be fasting, but also if you do a confirmatory 75-gram OGTT, it's a 2-hour value of greater than 200, and of course a fasting of greater than 126. Currently, the American Diabetes Association and ACOG recommends 6 weeks postpartum, a 75-gram OGTT. However, I was at SMFM this last week, and they presented an interesting study of doing an immediate 75-gram 2-hour GTT, which I hope will be published soon so we can look at the data, but it appears that it correlated fairly well with the 6-week postpartum, and they did not miss any diagnosis of type 2 diabetes. The reason I'm so excited about this study is because it's very difficult to bring mothers back for postpartum screening. We have employed many efforts, including having our certified diabetic educators call patients and try to schedule them early in the morning for their 75-gram OGTT. However, still with that, I could only get about 40 to 50% of our patients to come back for postpartum testing. So again, I'm very excited about this study if it does prove to be worthwhile. Moving on to breastfeeding, because I think it can have some important impacts, not only short-term, but also long-term. As you know, pregnancy is characterized by insulin resistance, which we talked about earlier, but also elevations in fasting triglycerides is common. Breastfeeding, however, is characterized by improved insulin sensitivity due to weight loss, a decrease in lipids due to mobilization of fat stores for the production of breast milk. And all of this, of course, again, leads to weight loss. And this leads to lower rates of metabolic syndrome, particularly among mothers with gestational diabetes. And this was a nice study by Dr. Gunderson, who is an expert on lactation. And what she noticed was that there was a dose response in regards to the hazard ratio for developing metabolic syndrome in mothers who breastfed, so that mothers who breastfed for greater than 9 months had a higher reduction, and this is a hazard ratio here, in the development of metabolic syndrome if they breastfed. So it's very important to counsel our patients regarding not only breastfeeding, but breastfeeding for longer periods of time. And then there's long-term childhood effects of breastfeeding. So this was a study looking at mothers who were never breastfed, here in the black, mothers who breastfed 1 to 3 months, and mothers who breastfed greater than 3 months. And then they looked at the prevalence of childhood obesity in these children. And what they noticed was that there was a lower rate of childhood obesity among the moms who breastfed for more than 3 months. And this effect was even greater among those mothers who were obese. Again, remember, obesity is an independent risk factor for childhood obesity, and breastfeeding seems to modify that risk tremendously. So breastfeeding can help us modify the risk of development of type 2 diabetes, and also has long-term childhood benefits. But there's other trials that have shown us that we can have an effect in reducing the development of type 2 diabetes in people at risk. The first trial was published actually in Finland. It was the Finnish Diabetes Prevention Study Group, published in 2006. The duration of the trial was 7 years, and they did some lifestyle modification as well as some weight loss goals, and they saw a 43% reduction in the development of type 2 diabetes. There was also a Chinese trial, which was published in 2008, which had a 20-year duration, and again, they did lifestyle modification and saw a 46% reduction in type 2 diabetes. And the last trial was the one published here in the United States that looked at not only lifestyle modification, but a 7% weight loss, as well as activity level of at least 30 minutes a day. And this study followed patients for 10 years, and they saw a 34% reduction in the development of type 2 diabetes. They did a secondary analysis, which was published in 2008, looking at mothers specifically who had gestational diabetes. And what they looked at was in the placebo group, as well as a group of women who were prescribed metformin after the delivery and lifestyle intervention. And what they noted was that there was a reduction in the development of type 2 diabetes in the metformin group and in the lifestyle intervention group of about 50 to 53%, which is quite good. So about 6 women who had gestational diabetes need to be treated with metformin to prevent 1 case of type 2 diabetes, and about 5 so women are treated with lifestyle modification, can also prevent the development of type 2 diabetes later in life. So this is quite staggering and powerful information to have for our patients. And so the ADA recommends that at least annually, people who have prediabetes are assessed for the onset of overt type 2 diabetes. Patients with prediabetes should also be referred to intensive behavioral style intervention modeled after the DPP study and maintain or achieve a 7% weight loss and increase their intensity of physical activity to 150 minutes per week. They also recognize the use of technology, including internet-based social networks, etc., to achieve these lifestyle modifications. And also in women with gestational diabetes, particularly Latinas, the consideration for giving metformin therapy for the prevention of type 2 diabetes, as well as those with obesity, defined as a BMI of greater than 35. However, just to recognize that there are some long-term problems with using metformin, including some of the vitamin B12 deficiencies that have been noted. And also, women have to have insurance, and unfortunately, this is a problem for our Medicaid patients. I want to thank you for your attention. I hope I'm able to answer some questions regarding the best practices to care for women both preconceptionally as well as interconception in mothers with gestational diabetes as well as type 2 diabetes. Thank you.